Good afternoon, ladies and gentlemen. Welcome to Lifestyle with Dr. Moby. Today we're going to talk about an important topic, which is irregular heartbeat and especially atrial fibrillation. So a lot of people don't know what it is, and just for brief intro about it, it is one of the leading cause of problem with stroke and medical complications as a result of that. So we have to really learn about it. I'm sure a lot of audience watched programs and they saw ad about blood thinners and they start wondering what is AFib or atrial fibrillation or AF. These are all names which most advertisements show. So we want to first learn what they are. And so atrial fibrillation in essence is a problem with irregular heartbeat. Heartbeat between 60 to 100 beats per minute, and it behaves very regularly, it beats very regularly, and if it loses that rhythm, and rhythm is generated by pacemaker in the heart, which sends a signal to different parts of the heart, and that is the electrical wiring. If that wiring is faulty, or the pacemaker is faulty, or the part of the heart is damaged, then it will cause problem with the rhythm and the beating of the heart. So we're going to learn from one of the experts in elderly geriatric medicine, Dr. Jamil Ahmed. Dr. Jamil Ahmed, welcome you to our program.
Yeah, thank you.
Thank you for coming. Tell us about yourself and your practice to the audience.
I'm an internist. It means I take care of adult medicine people, and I'm also a geriatrician, and I have a lot of geriatric people. And as we're getting older, we have a large geriatric population along with their complications.
Okay, good. Okay, so tell us where do you see with atrial fibrillation in your practice with elderly?
We have a lot of people that has atrial fibrillation, and most of the people who has atrial fibrillation probably they don't know, because sometimes it can be irregular pulse, sometimes it happens once in a while, so they tend to ignore till something happens. Before I go into any more detail about atrial fibrillation, it's only 100 years ago that EKG machine was made. It was built by a scientist and also a physician. His name is Dr. Arrythmias. He was born in Java, Indonesia, but at that time Indonesia was under Dutch colonial control, so they are actually Dutch. And then he went back to Netherlands and became a doctor and things like that. And he invented the machine. At that time, it took 5 people to operate that EKG machine. It's a big thing, and it's almost 600 pounds. And on that machine and the contribution that it caused in our healthcare, in the life of people, he got Nobel Prize.
Okay, very good, very good. So tell us how common it is in elderly.
It is almost 2 to 10% people have this disease that we know, depending on what ages. If you are 80 plus, there's almost a 10% people have atrial fibrillation. You know, when you think about rhythm problem, it is not one thing. You know, there's a 2 part in the heart. One is electrical system that creates the impulse in the heart. They're called pacemaker, and then goes to the electrical system to the both sides of the heart, and it squeezes. Another is a plumbing part, that when it squeezes, the blood goes through the system into the arteries, then to the brain, then to the extremities, all the organs in the body. Body couldn't survive too long without having continuous blood supply that carries oxygen with it. So, you know, we have to have two systems going simultaneously good. But when one system goes wrong, then other system cannot function well too long. There is a three different things can happen. Suppose your heart rate is low. It can be from the medication, then you hold the medicine.
Yep.
If it is some disease that causing your pacemaker to slow down, then you need a pacemaker. For rapid heart rate, you can have sometime medication to slow down, and sometimes it can be not too fast, just irregular, and that time we term the atrial fibrillation or AF, and that will be our topic of discussion today.
Good. Okay, so tell audience a little bit about what are the risk factors for people developing atrial fibrillation.
Before I get to that, and why do you care about atrial fibrillation?
Yes, that's true.
Yeah, it is because it is not only irregular heart rate. It's gonna make you feel tired. It will cause stroke that most of the people are afraid of, because that will change your lifestyle almost 100%. And how often this happens? You know, if you are aged 50, frequency is probably around 2.5%. And as you get older and going to 80s, it will be 8 to 10%. Now in the United States, we have 12 million people that have atrial fibrillation. As our population will get older, as expected because of the growth of aging population, and that expected that it will be close to 33.5 million people. So a lot of people will have issue with atrial fibrillation and the complication like stroke. So why do you worry about? As we say, you worry about it will increase your all-cause mortality in your lifetime. Stroke will be 5 times higher than other people. 20% of all stroke has atrial fibrillation. And the way it happens that when your heart is fibrillating or not rhythming, is going in sequential rhythm, one part becomes static, and blood will stay there for long enough to cause a clot formation. The only thing it can do is go up the plumbing system into the brain, and when that happens, you get a stroke. Since it's come from one part of the system to the other part, we call it embolic. Since it came from heart, went into the brain, it is embolism. And when that happens, the prognosis is much worse. If it happened in your brain just by process of degeneration, atherosclerosis, the narrowing of the artery, but they have their own problems, but embolism is much worse than atherosclerotic stroke. It will change your quality of life, and it will cause congestive heart failure because part of your heart function is decreased by 30%, and memory issue from the small stroke that happen, or we call TIA, over time can cause dementia. A lot of people with the dementia has atrial fibrillation. It's not a surprise. So who will develop, you then come to your question, who will develop atrial fibrillation? And if you think that 80% of people who has atrial fibrillation also has some sort of heart disease. They have a history of heart attack. They have a history of problem with the heart valve, and also has disease of the heart from congenital issues. Then comes the other disease, not from the heart. Suppose you have a overactive thyroid, which is not uncommon. When that happens, your heart gets very irritable. It starts to flutter, fibrillate, and if you do not control, it's not only bad for heart, also bad for everything, the way you feel. because it's going to make you tired, hyperactive once in a while, your heart going to fibrillate and complicates. Then is sleep apnea syndrome. This is getting more common than it used to.
Yeah.
We are getting overweight.
Yeah.
That has a correlation with sleep apnea syndrome. And we always look into the size of the neck to see whether patient is at risk for sleep apnea syndrome, other than wife will complain that he snores all night. And the lung disease. People who are a smoker, they also put a strain on the heart. And COPD, long-standing COPD, and they still continue to smoke and continue to get worse, will have more atrial fibrillation. And other infection like pneumonia, and we see that in the hospital, sometimes when the pneumonia gets better, they also get better. And lastly, everything has a genetic basis. Some people will have a more atrial fibrillation than other people, just because the family has strong history of atrial fibrillation.
Okay, thank you for making that clear to audience. So it's very important that we pay attention to this risk factor lifestyle. So it is important that if we gain weight, it's going to increase our risk. Blood pressure, if it's not under control, it will cause the heart to get bigger and cause a lot of problem, and also narrow the arteries, and a lot of can have heart disease with it. Because that is unfortunately is a systemic disease. Same thing happens if you have sleep apnea. Lack of oxygen will cause heart to have irregular rhythms, and atrial fibrillation recurrence, especially if it keep on happening, is a big problem if they have sleep apnea with it. So we need to diagnose and treat it accordingly, and really improves a lot of these factors. Other thing is about stroke. Remember, both types, whatever is the cause, the outcome is actually very serious, which can result in loss of part of the brain, which we call stroke. A lot of people have this misconception about mini stroke, and we'll talk a little bit about that, and they tend to minimize the effect and say, oh, it was just mini. Well, mini doesn't mean that it wasn't serious. Just to be clear here, mini strokes means that the part of the brain which died was very small or did not have a big effect, but it means that you have to take care. You're lucky that you got lesser damage, because next time it can happen, even next week or even next month or pretty soon, then it could be a major stroke. Okay, so do not take that very lightly, because mini stroke is very serious. So please pay attention to those risk factors. So let's talk more about atrial fibrillation.
Okay, just to get a better grip on this, and I'll give you a scenario.
Yeah.
You know, a person named John, just giving a name.
Yeah.
He's overweight.
Yeah.
And has a history of sleep disorder or a sleep apnea, and also smokes. Also has diabetes. Normally you can see this type of issue often in the hospital. Has high blood pressure, smokes, sleep apnea. It is not uncommon.
Yeah.
And they came to the hospital because leg is swelling up for 2 months and feels tired for 2 months. It's a clue that patient may have congestive heart failure or heart failure for some reason. It may be from the heart attack, or just because of the chronic lung disease, it is straining the heart. This time the patient came to the hospital because left side of the face started to droop. And you see the ad all the time, if your face starts to droop, worry about stroke. And he also had a arm swelling, weakness. And he couldn't talk well. So he has all the clues to tell you that this is a stroke. So when patient comes to the hospital, what we do normally, we have set things to do, like we get an EKG to make sure that he didn't have a heart attack,
Mm-hmm.
or he didn't have an atrial fibrillation,
Mm-hmm.
or any arrhythmias.
Mm-hmm.
Then we get an echocardiogram,
Mm-hmm.
which will look into the plumbing part of the heart,
Mm-hmm.
EKG for the electrical system.
Mm-hmm.
So that will tell how weak is the heart is, or not weak. So it doesn't matter what it is, that's the protocol you have to follow through.
Yeah.
Then we get a CAT scan.
Mm-hmm.
We do a CAT scan to make sure that patient doesn't have a bleed in the brain, because sometimes when people come to the hospital with a symptom of stroke, you always prepare yourself to give a clot buster
Mm-hmm.
to break down the clot. If you can do fast enough or early enough, within few hours, and there's a protocol how many hours you have to be, or if it's too late, you cannot continue. So doctor in the emergency room will take it very urgently, get a CAT scan quickly so that they don't lose any time. And even in spite of that, if this thinks that it is a blood clot cannot be done, then you have to decide what to do next. Because a stroke, you cannot do anything about it right now, but you have to take care of the underlying problems.
Mm-hmm. Okay, great. When they come to, so those are the risk factors, very important. Tell us about what is the therapy we can offer them, somebody with atrial fibrillation. So,
If somebody has a atrial fibrillation for unknown time, then you have to give some medication, because you make sure that there's no clot in the heart. Because if you try to convert the heart to regular rhythm, you can throw that clot into the brain and cause a problem. So standard is to give them blood thinner for 30 days approximately. And because after that you're going to start on some blood thinner. Blood thinner are two kind. One is the dependent on vitamin K, another is not vitamin K dependent. So people who take vitamin dependent Coumadin, which is in the market for many years, and probably helped a lot of people. And only problem is that it needs to be checked routinely, because if it is too high, then it can cause bleed somewhere else, including the brain, which will be very difficult to control. And there are other medications like aspirin, also good for stroke and the atrial fibrillation. To figure this out, there's scientists and the researchers, they looked into different factors which will involve in this risk assessment. They come up with few numbers. Like one is that whether patient has a congestive heart failure, whether patient is hypertensive, is he under 75 or over 75, or has a diabetes, or has a heart attack history, or female. Anybody has a 2 risk factor should be on a blood thinner. It means that either you have to be on Coumadin or warfarin or newer medications. If you think that way, as we get older, we see a lot of people has high blood pressure. And if it's a female and has a high blood pressure, she is a candidate for a blood thinner, and have to make sure that she is not at risk for stroke, fall and head trauma, or at risk for GI bleed. In that case, you have to worry about what to do. But something can be done. And anybody has a 2 positive number, like hypertension and age over 75, or diabetes and has a history of heart attack, or has a history of congestive heart failure and a female, they'll all be a candidate for a blood thinner. What else we have other than Coumadin? As I told you, there is vitamin K dependent and non-dependent. The newer medications are non-dependent. It means that you don't have to worry about how much vitamin K they are taking. And so they don't have to worry about going to a restaurant and not eating green because they're going to reverse the vitamin K and put them at risk for stroke. So, but newer medications are good on that ground, but it's very expensive. So you have to consult with your doctor, consult with your insurance company that these are covered. Most of them, they are covered because they are going to save patients' life, and they're going to cost insurance company much less in the long run because of the debility and the stroke and all the risk factor that comes with it. I can give you a few names. I give you like a trade names because it's easy to know, because otherwise it's a long names. Xarelto, Eliquis, and the Pradaxa. These are similar kind, but not exactly same. But it works, serves a purpose, and it can be replaced. It can replace the Coumadin if somebody needs it.
Okay, well, thank you for clarifying that. So what he is saying is treatment has a couple of important points here. First is, if duration is important. So some people can develop that quickly. So if they feel their pulse is fast and feel heart irregular or feel palpitations, then of course see the doctor and get checked. So we'll do EKG echo and come up with a diagnosis if it is atrial fibrillation or not, and could be just temporary or as a result of infection or so. And the treatment phase depends on the risk factors. So sometimes we like in the hospital to convert back to normal if it's quick enough, and then we might use blood thinner depending on if it's long enough, or if we do echo and if we see blood clot there, then because problem is sometimes if they try to cardiovert or change it to regular rhythm, can throw the clot up. So those are concerns, valid concern, because that as we learned before, one of the important cause of stroke is the clot from the heart going to the brain. And so that is a valid concern. Then we control the rate. So the rate could be very high, and then we want to bring it at least manageable range, 60 to 100-ish range, and watch it. We use certain blood medications or actual pills that might help to slow that down. Then we give blood thinners. So blood thinners are either aspirin. So Dr. Jamil indicated there's a criteria we use, and one of those, of course, being congestive heart failure or heart failure, where people can have a problem with swelling, shortness of breath, and those high blood pressure, diabetes, and female or male. So that all depends and age above a certain limit. So that is especially 65. So those are risk factors. We categorize that. So aspirin, whether they need more than aspirin, which is Coumadin, which is a rat poison. If you know about that, Coumadin thins your blood, and it can interfere if there's somebody is taking vitamin K. So it can cause problem with absorption and effect of Coumadin, and that is it should be monitored. Now we have newer medications which are expensive but work great. And talk to your doctor, cardiologist, to get that proper care, who needs blood thinner and so forth. And if you have never checked for sleep apnea, that's a very big important topic to highlight here, that we need to get that checked, and also get echo of the heart. And many times cardiologists might do stress test and cath, check your arteries, blood flow, and if there's a blockage, they'll open it up. So all those has to be done. Then those are very important part of these treatment strategies. So also, if we can come up with final thoughts for patients, if you want to highlight those.
if you really suspect that patient has atrial fibrillation and you do an EKG and it says normal, what we do is send the patient for called event monitor for 30 days. And because sometimes it may happen at night when they're sleeping.
Yeah.
So they will not know, because at that time oxygen goes down and it can irritate your heart. So it is a issue that you all have to keep in mind. Even if you see somebody has a mini stroke and you think that he may have atrial fibrillation, it should be pursued a little bit harder. And if you think that is somebody older and he's at risk for bleed, if you compare the people who took the medicine and how many people have bled, they always did better because of they didn't have enough of this stroke to cause them to die or something like that, or debility. So GRB probably can be managed if it's not too much. Sometimes it'd be too much, then there's no other choice but to stop. And daily exercise is good for heart, mind, and everything else. You know, there is no medicine to replace exercise. And it's a good thing to do. It's also good for atrial fibrillation. And I think it makes you feel better, your heart is better, and so you don't get complications like atrial fibrillation in the long run. If somebody overweight, if they lose weight, they will have less atrial fibrillation. So you check your thyroid problems, you lose your, make sure that you lose your weight, and then probably you'll get a lot of benefit just by playing safe and doing safety things that we do in life, like wearing seat belt, getting the exercise every day, and eating modestly. And if you have dementia, your likelihood to have